हेलो। हेलो।
Greetings from National Academy of Medical Sciences, India. Focusing on NAMS Vision 2030, NAMS is pleased to share some of the important activities like NAMS National, International Fellowship and Membership, Member After Day NBIM NAMS, NAMS Task Forces, AIMS NAMS Navigate Medico CME, CME activities, publication of annals, newsletter, networking with professionals, public orations, Young Scientist Fellowship, Scientist Exchange Program, scientific visit of Emeritus Professor and many more activities. All application forms for fellowship, membership, associate fellowship, and member after day NB have been made online and objective criteria from the year 2022. NAMS has also started a new online NAMS Navigate CME and Navigate Medico CME program to assist in the development of competencies among PG students and share multimedia learning resource materials as e-library. NAMS has also started 21 task forces to address medical issues of national importance. Under publication activities, NAMS has its own annal as Annal of the National Academy of Medical Sciences. In addition, NAMS also publishes its quarterly NAMS newsletter. For more details of NAMS activities, please visit our NAMS website www.nams-india.in or scan QR codes with the camera app. Greetings from National Academy of Medical Sciences, India. Focusing on NAMS Vision 2030, NAMS is pleased to share some of the important activities like NAMS National, International Fellowship and Membership, Member After Day NBIM NAMS, NAMS Task Forces, AIIMS NAMS Navigate Medico CME, CME activities, publication of annals, newsletter, networking with professionals, public orations, Young Scientist Fellowship, Scientist Exchange Program, scientific visit of Emeritus Professor and many more activities. All application forms for fellowship, membership, associate fellowship, and member after day NB have been made online and objective criteria from the year 2022. NAMS has also started a new online AIIMS NAMS Navigate CME and Navigate Medico CME program to assist in the development of competencies among PG students and share multimedia learning resource materials as e-library. NAMS has also started 21 task forces to address medical issues of national importance. Under publication activities, NAMS has its own annal as Annal of the National Academy of Medical Sciences. In addition, NAMS also publishes its quarterly NAMS newsletter. For more details of NAMS activities, please visit our NAMS website www.nams-india.in or scan QR codes with the camera app.
Hello, Dr. Jaswant.
Yeah. Hello. Good afternoon, ma'am.
Good afternoon. So you tried now the slide. It's playing the PPT.
Sorry, ma'am. I couldn't hear you. Yeah, please. Yeah.
It's playing the PPT. The PPT is working fine.
Yes, ma'am.
Yeah. Okay.
Yeah.
Okay. Right.
We'll also check it before once you start it. So before starting, we'll again
Okay. Yeah. Yes.
Yes, ma'am.
Dr. Kavita ma'am, I have just checked your PPT. It's working fine.
Okay,
I am Ravi this
thank you.
side.
Okay.
But you will display all these PPTs from your side?
I can display from my side also.
Yeah, you
I can
because
share.
otherwise you have to tell me the next. So
No, then it's better. So
it's
should I
better.
try and see? I think I'll just try to share the
Yeah,
PPT.
sure. Yes.
Like we will have better control, ma'am.
Yeah.
Like,
Yeah, in fact, I had requested Dr. Kavita basically because last time with Professor Vikas, there was a problem in transmission because of rain. So that is why we have done the contingency arrangements actually.
Sir, good afternoon, sir. Namaskar,
हाँ
sir.
हाँ, आपका ऑरा बड़ा जबरदस्त है, पीछे से पूरा चमक रहा है.
Oh, क्या बात है, sir? Yeah, I'm very fond of, plants. So my room is full of greenery.
good afternoon, sir.
हाँ, बेटा.
Ma'am, can you share your slide just
Yeah,
for the checking purpose?
Yeah, I'll just share it.
हेलो, हाँ जी सर, गुड आफ्टरनून सर, रवि बोल रहा हूँ. आपने ज्वाइन कर लिया, जस्ट एज इन्फॉर्म किया आप ज्वाइन कर लीजिए. श्योर सर, श्योर. थैंक्स.
Yeah, is this visible?
Yeah,
Yeah.
this is visible, ma'am.
Okay. Now I just stop your share because I have to start the program.
Correct. Fine.
Sure.
Greetings from National Academy of Medical Sciences, India. NAMS has been recognized by the Government of India as a nodal agency for promoting the continuing medical education for medical and biomedical professionals. National Academy of Medical Sciences encourages and sponsors nationwide CME programs, symposia and workshops in medical and biomedical professionals. NAMS is pleased to announce the launching of a joint AIIMS NAMS Navigate CME program from 1st September 2023 for postgraduate students in all the AIIMS and other eminent institutes of national importance from Andhra Pradesh, Arunachal Pradesh, Assam, Bihar, Chhattisgarh, Goa, Gujarat, Haryana, Himachal Pradesh, Jammu and Kashmir, Jharkhand, Karnataka, Kerala, Madhya Pradesh, Maharashtra, Manipur, Meghalaya, Mizoram, Nagaland, Odisha, Punjab, Rajasthan, Sikkim, Tamil Nadu, Telangana, Tripura, Uttar Pradesh and Uttarakhand of the country. The program is being conducted online on the first Friday of every month from 3 p.m. to 5 p.m. The AIIMS NAMS CME focuses on the topics which are of common interest for the postgraduates across all specialties. The aim of the National Virtual Postgraduate Medical CME is to help them to be more proficient in their profession. Each session will cover 2 topics. Each topic will be of 1 hour duration, which includes 45 minutes for presentation by speaker, 15 minutes for questions and answers. Thank you for your kind support.
Hello and good afternoon, everyone, to the next session of AIIMS NAMS Navigate CME program. And in the ongoing ophthalmology series, we all have learned of various topics. So in the recent discussion, we all learned the medical management mainly using topical medications, also oral medications. So there are many situations where these topical or oral medications or laser therapies, these are not efficient enough, or we can say these are not effective. So once IOP is not controlled, it continues to damage retina and the optic nerve. So this is very, very important topic today that we all are going to witness, that is surgical management of glaucoma. So considering the importance, I thank you, the speaker for today, Professor Dr. Kavita Bhatnagar ma'am. So to continue the program, I would like to request and invite Professor Ajay Kumar Sood sir, Deputy Secretary of National Academy of Medical Sciences, for the welcome address. Over to you, sir.
Thank you, Dr. Jaswant. On behalf of the National Academy of Medical Sciences, it is indeed my great privilege and honor to welcome the distinguished speaker for this afternoon, Professor and Head Department of Ophthalmology from AIIMS Jodhpur, Professor Bhatnagar. Madam, thank you so much for your valuable time. And I am sure the topic which you are going to cover, that is surgical management of glaucoma, will be of great importance to all of us, especially for the PG student. I am sure that the practical tips which you are going to give will be very, very useful for them. Thank you so much, Madam, for joining us. I also take this opportunity to welcome the Chief Coordinator for this series on ophthalmology, Major General J.K.S. Parihar, sir. Thank you, sir, for your support and blessing. We have identified the best speaker and the best topics for our students. So we look forward for your blessing in future also. I also extend a warm welcome to all the faculty members and the PG students who have joined us in this session. And it is your own program, and your support and blessing we always and suggestion we always seek. My request and appeal to the PG student, this is the best opportunity for you to interact with the best speakers. So kindly share your question and queries on the chat box, and our speaker will be happy to answer. So once again, warm welcome to all of you for this session, and we look forward for a very interesting and interactive session. Over to you, Dr. Jaswant.
Thank you, sir. So I would like to request Mr. Raviji for a message from President of National Academy of Medical Sciences.
My dear young colleagues, faculty, and officials of the National Academy of Medical Sciences, a very good afternoon to all of you. With immense pleasure, I invite you all to this program. National Academy of Medical Sciences, that is NAMS India, it was established on the 21st April of 1961 with the objectives of promoting the growth of medical sciences. It was inaugurated at New Delhi on 19th December 1961 by Pandit Jawaharlal Nehru, the first Prime Minister of India. The NAMS fosters and utilizes the academic excellence of health professionals in the country as its resource to promote excellence in medical education and skill development in the field of medicine and allied sciences. The Government of India has recognized the Academy as a nodal agency for promoting continuing medical education for medical and allied health professionals and is advising the Government of India on several matters of national health policy and planning. The best in the field of medicine are part of this umbrella organization, and who is who of medical science guide the NAMS. The National Academy of Medical Sciences encourages and sponsors nationwide CME programs, symposia, and workshops in basic sciences and applied clinical disciplines. The aim of the National Virtual Postgraduate Medical CME is to facilitate the postgraduate students and young faculty members to increase their knowledge in the medical subjects, to navigate them to be more proficient in their profession, and pass their NEET and PG examination to become better doctors, eminent biomedical scientists, teachers, and researchers. As a part of this responsibility, NAMS, in collaboration with the AIIMS New Delhi and 16 other AIIMS-like institutions of the country, has initiated this navigation program in the form of dialectical lectures and discussions. The program is regularly held every first Friday of the month at 3 p.m. The best and useful topics are carefully chosen, and the best teachers from various aims are picked up to prepare and give these lectures. I am sure you all will enjoy these talks and will like them and found them useful in your future lives. Thank you.
Thank you. Raviji, please, I would like to request you for the message from Professor Director NAMS-AIIMS, Director AIIMS New Delhi. So, yeah, please.
Namaskar. At the outset, I congratulate the team behind the NAMS-AIIMS Navigate CME program. Providing quality of education to our postgraduate students is one of the prime responsibilities of AIIMS. I know that our able faculty is leaving no stone unturned in achieving this mission. However, there always remains a scope for improvement. Through this unique initiative, there is an opportunity for our postgraduate students to learn from the experts in their field. This learning will go beyond the boundaries of department where our postgraduate students are working and will also bring in more flavor in their knowledge and at the same time ensure dissemination of uniform, high quality content all across the nation. Postgraduate students also form our primary workforce for providing patient care. This indeed is an important component of their training. We are aware that our postgraduate students devote a large component of their time for the patient care services and thus they have less time for self-study by the end of the day. The timing of this activity is therefore very carefully chosen. The sessions will be held late in the afternoon so that the beneficiaries do not have to make any extra effort for attending them. This by itself exudes the philosophy of a true teacher, a mentor that will handhold the children through the process of their active learning. As the sessions are online, which by its very design is a non-synchronous platform, it may seem that the delivery of the content will be one-sided, but enough measures have been planned and they are in place to make the activity as interactive as possible. The topic of the session will be shared with the students well in advance. This will allow them enough time to explore the subject and be better prepared to absorb the content. This design, therefore, also matches the concept and principles of adult learning. The program not only will help our postgraduate students in being better prepared for their examinations, but also will equip them with sufficient knowledge, understanding, and approach to be a better professional in their field. I wish this program all success. Thank you.
Yeah, thank you, Raviji. So, in order to continue the program, I would like to introduce briefly about the chief coordinator of this ophthalmology series, General J.K.S. Parihar sir. Sir is professor of ophthalmology and head academics and trainings at Center for Sight at New Delhi. Sir has also served as additional DGAFMS formerly. And we all know that Sir has numerous publications and numerous awards in his name and a huge teaching experience of more than 35 years. So with this brief introduction, I would like to invite General Parihar sir for the address from his side. Yeah.
Thank you, Dr.
Over to you,
Jaswant,
sir.
for the kind introduction. I am really happy that you did not waste time in reading the whole slide. Highly appreciated.
Sir.
I really appreciate it. And my heartfelt thanks and gratitude to the entire National Academy of Medical Sciences, our dynamic leader, Professor Mehra, earlier Professor Sareen, and incumbent President General Velu Nair, Professor Umesh Kapil, Professor Sood, and all of you. I am so happy to see that this CME navigation program is going very happily and it attracts a lot of enthusiasm amongst the PG students. And whatever we could contribute little bit to enhance the standard of the postgraduates in our country is for us a great opportunity. With this short note, I welcome Professor Kavita Bhatnagar, and former introduction will be there, but she is a very dynamic and pushing ophthalmologist and educationist in medical education. I am deeply benefited the way the things have improved in AIIMS Jodhpur. Thank you very much.
Thank you so much. Thank you so much.
Thank you, sir. As sir introduced, that ma'am is professor and head of the Department of Ophthalmology at AIIMS Jodhpur, with again teaching experience of around 30 years and numerous publications and award in her name. So, without wasting much time, as we all know that both of you are renowned faculty of ophthalmology and in medical sciences. So, without wasting much time, I would like to hand over the mic and dice to you, ma'am, for the discussion and presentation. Thank you, ma'am.
Good afternoon, everyone. At the outset, I would like to congratulate and thank National Academy of Medical Sciences organizers for the CME. Thank you, Professor Bhera sir, Professor Sood sir, Professor Umesh Kapil, and General Paryar sir for giving me this opportunity to be part of this CME series. And thank you, dynamic moderator, Dr. Jaswant. Thanks for a brief, good introduction. Okay, let me just share the screen. In fact, it's a great initiative. This NAMS-AIIMS PGI Navigate CME is a great initiative for our postgraduate students, and I'm sure they will benefit from this series.
Just click on ma'am, share slide. Yeah.
Is it visible? Is the screen visible? Because I can't see the screen.
Your entire screen is visible, like your own video is coming again here.
Just
So
open your file.
open the file, that PPT.
Yeah. Is it visible now?
No, ma'am.
No?
First
Okay,
you open
last time
the
you presented that particular window. So there are multiple windows that you will see after clicking the button share screen. So you just need to click on that particular button, like which is showing that presentation PPT.
I clicked on that.
first you open
tried
the
sharing it earlier. It was visible, but
first you open the file and then share the screen.
Yes.
it's
मैं कर देता हूँ. Yeah.
Yeah.
Just click on the full screen. This one.
तो नीचे आप उस पे आप अपने स्क्रीन पे मैम नीचे जाइएगा जहाँ पे पीपीटी है, टास्क बार।
पीपीटी पे क्लिक कर दीजिए मैम।
नीचे जी मैम।
इस पे
यस, यहाँ पे फुल स्क्रीन मैम। यस, थैंक यू मैम।
Is it visible now?
Yeah, it's very well visible.
Okay. Okay. So I'll start.
Yes, ma'am, please.
Yeah. Okay. So a very good afternoon once again. So we'll be discussing surgical management of glaucoma. I have no financial interest to disclose. So I'll be covering my topic under these headings: introduction, risk categories and management principles, management options, surgical management, indications, types, preoperative assessment, and detailed discussion on trabeculectomy, GDDs and MIGS. A brief overview of glaucoma. It's the second leading cause of blindness globally. It's the leading cause of irreversible blindness globally, which affects more than 70 million people worldwide. And the estimated number of cases of glaucoma in India is 12 million, which is about 1/5 of global burden of glaucoma, which is quite alarming. And the predictions are by year 2040, it is estimated that 111.8 million people will be affected by glaucoma, so which is quite alarming. Uh, what is glaucoma? It's a neurodegenerative disorder characterized by retinal ganglion cell death, progressive glaucomatous optic neuropathy, and glaucomatous visual field defect. Loss of RGC occurs despite IOP reduction. That is why managing glaucoma is very difficult, and as RGCs cannot regenerate, optic nerve damage is irreversible. Now coming to management options, the risk categories and management principles, the key points are, which you should remember: the treatment is indicated when risks of progressive disease outweigh the risks and potential side effects of treatment. The treatment decisions should consider presence of coexisting ocular conditions, patient's life expectancy, general health status, and patient's perceptions and expectations about treatment, which is very important. And the rate of disease progression is of fundamental importance. So, taking into account all these factors and status of fellow eye and family history, target IOP should be calculated, recorded, and it should be a dynamic time target IOP. So it should be periodically re-evaluated. It's not that you set target IOP once and then it will be the same throughout the management period. Goal of glaucoma treatment is to maintain patient's visual function and quality of life at a sustainable cost. So all three are important. The cost can be calculated in terms of inconvenience and side effects, as well as financial and social implications for the individual and society. Options are medical, laser, and surgical. I will not go into details of medical and laser treatment. Quality of life is very important to be considered when deciding on management. We have done this project in my institute where we have compared quality of life in medically and surgically treated glaucoma patients, and our surgically treated patients had much better quality of life. This is accepted for publication in Indian Journal of Medical Research and will be soon available to you. And ocular surface is another factor which should be thoroughly evaluated before embarking on treatment. So we have done this two big projects on ocular surface changes in glaucoma. In this study, which is published in Indian Journal of Ophthalmology, we have compared ocular surface changes in primary open-angle glaucoma on anti-glaucoma medications versus treatment-naive patients, and we have found that ocular surface is significantly damaged due to long-term anti-glaucoma medications. So this should be diagnosed and treated side by side. Now coming to surgical management of glaucoma, the general principles are: the goal of surgical treatment is to achieve long-term lowering of intraocular pressure with, to the individual target with an aim to minimize risk of further optic nerve damage. So We want to maintain IOP so that further optic nerve damage doesn't occur and we can preserve whatever vision patient has or delay the loss. The decision to perform glaucoma surgery and type of surgical procedure must be carefully chosen after a comprehensive risk-benefit analysis for each case individually. One size doesn't fit all. And to maximize chances of success and minimize complications, as no surgery is devoid of intra and postoperative complications. The factors affecting the threshold for surgical intervention are estimation of risk of progression, physical quality of life, and life expectancy of the patient. The types of glaucoma surgery are penetrating filtering surgeries, example trabeculectomy, non-penetrating, that is deep sclerectomy and viscocanalostomy, and aqueous shunt implants, Ahmed and Bawel, and MIGS, minimally invasive glaucoma surgery. The preoperative assessment is proper history and comprehensive examination, including refraction, should be done for all cases. We should have a look at what medications patient is on. It is advisable to stop pilocarpine as it increases post-operative inflammation. Also, it is recommended to stop prostaglandins 1 week before surgery, as they increase the risk of cystoid macular edema. Anticoagulants should be stopped 3 days prior to surgery. The ocular surface, like meibomitis, blepharitis, any allergies and associated ocular surface, ocular diseases should be evaluated and treated before surgery. The two major risk factors for surgical failure are history of previous surgery and history of inflammation. Now coming to trabeculectomy, which we will be discussing in detail, as this is the gold standard. It's a guarded filtration procedure that remains the gold standard for long-lasting intraocular pressure reduction in uncontrolled glaucoma, popularized by Kahns in 1968. Now, indications for TRAB are patients with failed maximal tolerated medical therapy or failed laser surgery or poor candidates for medical management or laser with any of the following factors. Progressive glaucomatous damage to optic nerve if it continues. Documented glaucomatous visual field loss, which are progressive. Intolerable side effects of glaucoma medication. Lack of compliance with glaucoma medication. Patients who are poor candidates for follow-up, especially in remote areas with poor access to healthcare, though it's an ethical dilemma whether to consider surgery or medical management in these patients. It is done under local anesthesia. Superior rectus traction sutures are taken for globe exposure. Conjunctival flap can be limbal based or fornix based. It's a surgeon's preference. I prefer fornix based conjunctival flap. Then scleral flap dissection is done. It provides resistance to aqueous outflow and prevent hypotony. It acts as a safety valve to minimize IOP fluctuations. The technique is the thickness should be half to 2/3 of scleral thickness, and lamellar dissection should be anteriorly just into the clear cornea. As you can see in these pictures, the flap can be rectangular, can be trapezoid, or can be triangular with size of 3 into 3 to 4 millimeter. I prefer a rectangular flap. MMC and 5-FU are antimetabolites which can augment your surgery in intermediate and high risk category patients. Its delivery, a cellulose sponge soaked in antimetabolites is placed under the dissected tenon's capsule for 2 to 3 minutes, followed by thorough irrigation with BSS. It's important. And try to cover largest area possible for more diffuse non-cystic bleb and prevent posterior limiting scar, that is ring of steel, as you can see here. Now, an oblique paracentesis in the inferior cornea allows fine control of AC depth. It allows IUP titration after tying the scleral flap sutures, helps in reformation or decompression of AC intra or post-operatively, which can be done with BSS or viscoelastics, and also helps in control and washout of AC hemorrhage if any occurs during surgery. Sclerostomy. So anterior entry reduces risk of iris incarceration and bleeding from iris root and ciliary body. You can either do a punch sclerostomy or you can do manual block removal. Size of 0.5 to 1 millimeter. As you can see here, a broad-based peripheral iridectomy is a routine part of all standard filtering procedures. It is performed from the sclerostomy side, but the extent should be beyond its margins to avoid obstruction of sclerostomy by the peripheral iris. Now, closure of wound. So, approximation of scleral flap is done with tenonylon that achieves mild to moderate resistance to aqueous flow, maintaining optimal AC. Aqueous flow resistance can be tested by injecting BSS through the paracentesis. Now, some surgeons prefer two loose sutures at the posterior corners to promote filtration around the margins of the flap, while other surgeons prefer tighter sutures which can be released post-operatively if needed, or releasable sutures are an alternative to suture lysis. Conjunctival closure must be watertight to have a good blab. May use cycloplegic eye drops at the end of surgery to relax the ciliary processes and prevent the chance of a very shallow anterior chamber. Now let us see a video of trabeculectomy. So fornix based conjunctival flap is made. A scleral flap is fashioned. Relaxing incisions are given on the sides. Then trabeculectomy, the sclerostomy, paracentesis to reform the AC, and peripheral iridectomy is done, and then you close the wound with tenonylon suture. What are the factors affecting efficacy of trabeculectomy? So efficacy is dependent on tendency for subconjunctival fibrosis, presence of releasable sutures, and if scleral opening is small, TM removal is in small area. So efficacy decreases with increased subconjunctival fibrosis, repeat surgery or previous ocular surgery, younger age, uveitic and neovascular glaucoma, high myopia patients, and nanophthalmos and aphakia. Efficacy increases with use of antifibrotic agents and removal of releasable sutures. Now coming to complications of trabeculectomy, like all other surgeries, trabeculectomy is not free from complications. In fact, sometimes complications may be more difficult and a Herculean task to manage than the trabeculectomy surgery itself. Now, this is the overview of post-op complications. So, early complications with any IOP can be high femur, Dellens and uveitis. With low IOP, we have if bleb is formed, it can be due to overfiltration. If early low IOP is with flat bleb, it suggests wound leak. If it's a big leak, surgical repair is required. If it's a small leak, then conservative management will be enough. If early high IOP is associated with deep chamber, then it suggests suprachoroidal hemorrhage. If it's a flat chamber, then it suggests malignant glaucoma. I'll discuss the management. In late complications, any IOP, we have cataract, infection, and uncomfortable blab. With low IOP, it can be overfiltration or leak or ciliary body shutdown. Late high IOP can be due to external block, internal block, or tight flap. I will now tell you the management of these complications. So for overfiltration, look for loose flap or choroidals. Start cycloplegics, atropine, 4 times a day. Decrease steroids, and if required, you can add aqueous suppressants. For a small leak, aqueous suppressants, you decrease topical steroids. For choroidal effusion, atropine 4 times a day to be started, and topical and systemic steroids to be started. Kissing choroidals or flat AC, then is AC reformation with choroidal drainage is to be done. For ciliary body shutdown or detachment, steroids frequent, atropine 4 times. Avoid beta blockers or carbonic anhydrase inhibitors. If you are suspecting cyclodialysis cleft on goni or UBM, atropine 4 times, decrease steroids. Organ laser with Goldman lens treats scleral region of cleft. For large clefts, definitive surgery is required. For retinal detachment, VR referral is to be done. Now, late complications, any IOP, cataract, of course, surgery. For uncomfortable blab, lubricants should be started, and if there are loose sutures, remove them. For blebitis, fortified antibiotics to be started, and withhold steroid for 48 hours, and cycloplegics, and close follow-up is required. For endophthalmitis, vitreous tap and intravitreal antibiotics with fortified topical antibiotics and cycloplegics to be started. For hypotonous maculopathy, address the underlying cause. Autologous blood injection may be tried, and compression sutures or revision. For delayed blab leak, surgical revision, CLAG or scleral patch graft or amniotic membrane. Now for high IOP, if it's due to internal blockage, YAG vitriolysis, needling or blab revision to be done. If it's tight flap, then delayed suture lysis. 1 to 4 weeks is the window, or blab needling with 5FU or MMC can be tried. If for you suspect external blockage, it's due to blab encapsulation or tenous cyst or conjunctival scarring, then you have to re-operate. Now, shallow AC with high IOP and cloudy cornea, then you are heading for malignant glaucoma. So start IV mannitol, systemic acetazolamide, intensive cycloplegics, topical aqueous suppressants. In these cases, no suture removal should be done and no blab massage. Sorry for the typo error, massage is missing here, so no blab massage to be done. So if this treatment is successful, continue it for a long time. If not, then for pseudophakic patients, large YAG hyaloidotomy to be done or PPV. If it's somewhat shallow AC with normal or high IOP, it may be impending malignant glaucoma. So intensive cycloplegics to be started with topical aqueous suppressants. Suture removal should be done only after the AC deepens. Now, if it's a formed AC with high IOP, do a gonioscopy to look for internal ostium, point massage blab and reassess the blab status. If it improves, fine. Otherwise, remove releasable sutures, or if not, releasable sutures are not there, laser suturolysis to be done, and ocular hypotensive medications can be started. If it's formed AC with high IOP, it can be due to suprachoroidal hemorrhage. Treatment again is IV mannitol, systemic acetazolamide, intensive cycloplegics, topical aqueous suppressant. Again, in this case, no suture removal to be done, and no bleb massage if you are suspecting suprachoroidal hemorrhage. So if this treatment is successful, monitor IUP and taper steroids steadily. If no, then the drainage of suprachoroidal hemorrhage with the help of VR surgeon is to be done. So that was about trabeculectomy. Now we move on to glaucoma drainage devices. With increasing experience with glaucoma drainage devices, they are now becoming more popular. The indications are eyes with severe conjunctival scarring, maybe due to traumatic, chemical, or inflammatory. Previously failed glaucoma filtration surgery, especially with antimetabolites. Neovascular uveitic and traumatic glaucoma. Previous intraocular surgeries with scarring, aphakic or pseudophakic glaucoma, refractory congenital or developmental glaucoma, and Sturge-Weber syndrome. In fact, now with increasing experience, people are doing GDDs even for primary glaucoma. Most commonly used materials are silicone, like in bowel, PGIMER, polypropylene, and hydroxyapatite, and expandable polytetrafluoroethylene. This increases vascularization of the fibrous capsule, increasing the efficacy and functional lifetime of the implant. The implant designs are open tube designs and flow restricted designs. In open tube, we have Molteno, Bowel, and Shocket. In flow restricted designs, we have Emmett and Kruppin valve. Emmett glaucoma valve is the most commonly used valved implant. Now, the surgical procedure for valved GDD: superotemporal 90-degree fornix-based conjunctival incision is made, and posterior dissection is done, and radial relaxing incisions are made. Corneal or limbus sutures enable the surgical exposure. Priming of AGV is done with BSS using a 26 gauge cannula. Then you suture the plate 8 to 10 millimeter posteriorly from the limbus using non-absorbable sutures. Then you cut the tube bevel up to a length approximately 1 to 2 millimeter in the anterior chamber. And then AC paracentesis is done using a 23 gauge needle, and through this needle track we insert the tube. Then you suture the scleral or corneal patch graft to cover the tube close to the limbus. And finally suture the fornix base flap over the implanted tube shunt. This is also not free from complications. No surgery is free from complications. So complications common to all filters are hyphema, hypotony, maculopathy, shallow flat AC, choroidal effusion, bleb encapsulation, aqueous misdirection, end-off, and loss of vision. Common to all GDDs, there can be conjunctival retraction, tube or plate exposure. There can be tube endothelial touch. Cornea may be decompensated, or bullous keratopathy. Tube may get blocked by iris or clot or vitreous or silicone oil if it's an oil-filled eye. There can be tube retraction or hypertensive phase. Non-weld in addition have hypotony and diplopia. Now let us see a video of GDD. So corneal stay suture is taken, conjunctival flap is made. Now this is the Emmett glaucoma valve. Tube priming was done with BSS, and then plate is inserted and 8 to 10 millimeter behind the limbus. This is anchored with the sclera. Then the needle track is made for entry into the anterior chamber. Tube is cut so that only 1 to 2 millimeter is inside the AC, and this is inserted through the needle track. And anchored onto the sclera. Now this is scleral patch graft is done to cover the tube. And it's closed. Now coming to minimally invasive glaucoma surgeries, MIGS. MIGS got US FDA approval in 2012. MIGS is the term applied to a variety of novel surgical procedures for glaucoma, which can provide a safer alternative to traditional filtration procedures in mild to moderate glaucoma only. So it has advantage of leaving conjunctiva untouched. So in case future filtration surgery is required, you have conjunctiva available to you. So this procedure involves minimal invasiveness with ab interno approach, minimal tissue dissection, higher safety profile, rapid visual recovery, and IOP lowering to physiological levels. The indications of MIGS are mild to moderate open or closed angle glaucoma requiring cataract surgery, mild to moderate phakic open angle glaucoma not compliant with medication or progressing despite medical management, and mild to moderate pseudophakic open or closed angle glaucoma patients interested in decreasing the number of eye drops being used to control IOP. The patients are not happy with eye drops, many of them. So preoperative assessment, gonioscopy is required before deciding on any mixed procedure. If the scleral spur is visible all around without indentation, any mixed procedure can be attempted alone, regardless of lens status. If the spur is visible all around only on indentation and the patient is phakic, then do not consider mix. If the spur is visible all around with indentation and the patient has cataract, then combine cataract and mix. Now, mix are classified based on the outflow pattern. With suprachoroidal outflow, we have side pass and eye stent supra. With Schlemm's canal outflow, we have trabectome, eye stent, hydrus, high frequency deep sclerotomy, GAT, and ab interno trabeculoplasty. As I told you, in 2012, it was only these procedures, only ab interno procedures, but later the mixed classification expanded to include MIBS, which is based on subconjunctival outflow, but it involves minimal scleral dissection. So this is a pressure flow microshunt, is from Japan, and Zen implant. So these are based on subconjunctival outflow. This actually US FDA approval was given in 2019. So now we have both MIGS and MIBS available to us, and these are gaining popularity now. Side pass and eye stent supra create a pathway for aqueous into the suprachoroidal space. The Zen implant drains aqueous into the subconjunctival space. The trabectome and Cahook dual blade, they are devices used for ab interno trabeculectomy. The eye stent allows aqueous to bypass the trabecular meshwork and drain into the Schlemm's canal. The hydrus implant allows aqueous to bypass the trabecular meshwork and also dilates Schlemm's canal. GET uses an illuminated microcatheter to create a 360-degree ab interno trabeculectomy. I'll be showing you a surgery video of GET. This procedure can also be accomplished using a 5-o-proline suture, which is called suture GET, which is less expensive option. And bent angle needle goniotomy or BANG is another low-cost alternative to GET. So of the above, most devices and implants are not currently available in India. What is being practiced is suture GET, ab interno trabeculectomy using Cahook or trabectome or BANG, and HFDS, that is high frequency deep sclerotomy. Now let us see a video on GAT, that is gonioscopy assisted transluminal trabeculotomy. So this is a illuminated catheter, microcatheter, which is being fashioned to cover 360-degree trabecular meshwork. You can see it coming out here. So advantages that, 360-degree trabeculotomy is done. With minimal scleral dissection. Other devices are express shunt, which is made of stainless steel tube with a barbed end to anchor it into the trabecular meshwork through which a stent is placed. This is drained underneath a traditional trabeculectomy flap. iStent is a stainless steel stent that is implanted from an ab interno approach, and this device traverses the trabecular meshwork and drain aqueous from the AC straight into the Schlemm's canal. And early studies are showing promising results. The Solex gold shunt is made of 24 karat gold and works to connect the anterior chamber and suprachoroidal space. Pressure in the suprachoroidal space serves as a natural counter pressure to prevent severe postoperative hypotony. It is implanted by using an ab interno approach, so no blab. Now, which is the best choice? Well, it depends upon what is the goal of surgery. So, trabeculectomy remains the gold standard for IOP lowering and ability to titrate downwards with early postoperative laser suture lysis. MIGs are less potent but provide a non-blab and safer option for certain patients and combine synergistically with cataract surgery with minimal impact to future filtering surgery. MIPS provide similar to slightly less potent IUP lowering than trabeculectomy, but in a more predictable and more controlled way, with less post-operative intensity and improved bleb morphology. This is gaining popularity now. So the key takeaways are: tailor your surgery to the patient and glaucoma type, mild, moderate, severe, or low risk, intermediate risk, or high risk group. Decision should consider the risk benefit ratio. Even though decrease in IOP is beneficial for preservation of vision, the risk of vision loss without surgery must outweigh the risk of vision loss due to surgery. Please remember this. Trabeculectomy remains gold standard. Scarring is the most common cause of surgical failure in trabeculectomy. Therefore, the risk factors should be evaluated. The use of antifibrotics is associated with a higher incidence of complications, but it increases surgical success rates. So, dose should be titrated based on risk factors and stage of glaucoma. Trabeculectomy lowers intraocular pressure more than the non-penetrating deep sclerectomy technique. However, the complication rate seems to be lower in NPDS. In eyes with previous intraocular surgery, there is insufficient evidence that tube surgery may be better than the standard trabeculectomy. Mix has expanding role. Even GDDs are becoming popular with increasing experience, and post-operative follow-up is crucial. So these are references and further reading. My acknowledgements. Thank you. So any queries or questions, I'll be happy to answer.
Thank you very much, ma'am, for the comprehensive presentation that included very clear videos, like even the known ophthalmologists, like even MBBS students or people from other branches, they could understand it easily, ma'am. And then flow charts.
Thank you.
Yes, ma'am. These were really uh, good. So, like, ma'am, one question that I could get on YouTube, ma'am, from Dr.
Okay.
Mohit Yadav, I will
Yeah.
read out, ma'am. Ma'am, I'll paste it here. Ma'am, in a patient with a hypermature that is
Hmm.
Morganian cataract and
Hmm.
uncontrolled primary open angle glaucoma. So, despite medical therapy, okay. So, what are the comparative outcomes and risk of combined phacoemulsification with trabeculectomy versus sequential surgery?
See, for uncontrolled primary open angle glaucoma and now Morganian cataract, the anterior chamber also will be very shallow. So, you have to start anti-osmotic agents like IV mannitol and try to clear the cornea. Once the cornea clears a little bit, try to do YAG PI before taking the patient to operation theater. So this will, help you from, unexpected, say, suprachoroidal hemorrhage or things like that during surgery. And I always use, intraoperative IV mannitol. So that actually, shrinks the vitreous. So it pushes the lens iris diaphragm backwards. So that helps in surgery. And in these cases, actually, I personally will prefer to combine SICS with trap. But yes, or you can do a trap from a separate, superior trap from a separate entry. Then, before doing iridectomy, do phaco from another port. And then finally you do, iridectomy and complete your trabeculectomy. So do it from different sides. So do trap first, then do phaco.
Thank you, ma'am. I would like to request the participants to raise their hand so that we can unmute them if they are unable to write it right now. They can just raise their hand and we'll unmute them. They can ask the question. Any query, any doubt they have. Or on YouTube who are watching us, they can just leave a message, leave a question in the chat box or comment box. Okay. So
If residents don't have any questions, either they have understood everything or they have not understood anything. And more commonly, they've not understood. But the PPT is available And I mean, you can, put your question. I think there is a link also to connect with the mentor. So I'll be more than happy to help them.
Ma'am, possibility of first scenario that you told that they have understood everything is more
Actually,
because
I
it
made
was
the
very
presentation
simplified
very
presentation.
simple for resident level.
Right, right.
Yeah.
That was very simplified presentation. So I don't think if anyone would have any doubt after seeing that presentation. So yeah, that was wonderful, ma'am. Okay, so thank you. We'll request the participants. They can email us if they have any query. We will connect you to ma'am, and we will provide answers to the queries. So I think if there are no more questions, then I would like to request Professor Ajay Kumar Sood sir for the vote of thanks. Over to you, sir.
Thank you. Thank you so much, Dr. Jaswant. Again, it is again my great privilege to thank the distinguished speaker for this evening. Madam, you have covered the session so well. I am not from clinical side, a public health person, but still I understood a lot of
Okay.
things, especially your video clipping, and a lot of efforts have gone. So we thank you so much. And I'm sure that the practical tips which you have given in the form of logarithms, our PG students have greatly benefited. Once
My
again, we
pleasure.
thank you for your support and blessing. And we hope that in future also we'll be supporting the
Oh,
academy.
sure. I'll
Thank
be
you
more
so much.
than happy.
Thank you
It's
so much.
my pleasure entirely, to be part of this NAMS, AIIMS, PGIMER, Navigate CME. I would love to continue to be.
Thank you so much for your blessing. I will also place on record the support which we have been getting from Major General J.K.S. Parihar sir. He has been as I said earlier, the chief coordinator for this series, and he has identified really the topic and the speaker which are the best. Thank you, sir. We place your effort on our record, and thank you for that. I would also like to thank all the faculty members from various institutions, AIIMS, as well as the PG students who have been participating in this program. In fact, this is your own program, so I request you to come forward to give your suggestion, and also faculty members can come forward to take topics of their interest for the PG students. So thank you so much. For the PG student, this series on ophthalmology is two more sessions are there. The next session is on 5th of September. And there again, we have a very interesting session on how to manage pediatrics eye trauma. And the speaker again is very prominent speaker from AFMC Pune, Colonel Jaya Kaushik. So please join us. And also, if you have any question and queries, you can write to us and we can sort of share these questions with the speaker so that these are answered. Another information for the PG student is that NAMS in collaboration with ICMR has started online biostatistical helpline to support you for your thesis work. And the details we have shared in the chat box. So it is free, and the eminent biostatistician from NAMS as well from the ICMR, they help the student. It is free. You have to just register as per your convenience, and the expert will be able to help you. Another information is that on 6th of August, that is next Wednesday, we have a distinguished speaker from Brixton Medical School, UK, Dr. Somnath Mukhopadhyay, and he is going to have a talk. Again, it is online talk from 12 o'clock to 1 o'clock on the new techniques in the management of eczema as well as the asthma in children. So this again session is going to be very interesting. So my request to the PG student and faculty member to encourage the faculty member as well as the student to join this session. For faculty member, we another interesting announcement. National Academy of Medical Sciences has been starting a leadership development program for the last 2 years now. The fourth program is due on 23rd to 25th of October. And we are opening this for registration. We have circulated the brochure on the chat box, and we are going to write to all the directors and faculty member of AIIMS and other institutions to participate in this program. So this unique program where you have the opportunity to meet with the best leaders in medical science, and they share their experiences. And this way, this program is different from other leadership program, that you get the opportunity to directly interact with the eminent leaders in the medical specialties. And I would like to thank again Dr. Jaswant, who has been helping us from the very beginning for moderating this session. Thank you, Dr. Jaswant, for your support to National Academy of Medical Sciences. Here, our IT team, headed by Mr. Ravi, and also supported by Mr. Shivam. They have been helping us in sending you the emails and also organizing this session transmission on Zoom as well as on the YouTube. So all these sessions are available on the YouTube. Also, you can have the link is on our NAMS website. So you can download this session as well as the PPT, and you can see it any number of times. So once again, I thank you all for joining us and making this session very, very interesting. So once again, I thank the distinguished speaker. Thank you so much, madam, for
Thank you
being
so
here.
much. Thank you. Thank
How
you.
about you, Dr. Jaswant?
Thank you, sir. Thank you very much, ma'am. It was a really wonderful presentation. And sir, I think with your permission, we can mark the closure of this session.
Thank you.
Sir, thank you, sir.
Okay, thank you. Bye-bye.